So this is one of the patient who was referred to our service, and we all have discussed about his uh, plan, and I'll just go step by step with his history, examination, investigation, and then what we think is appropriate for his final disposition for his disease. And we did discuss our cases in our CTF meetings every month. And so, is it this? What did I do wrong? It's my disclosures. So this was a 64-year-old Caucasian male who was sent to us with history of pulmonary hypertension. He was, prior to presenting to us, he was treated with PD-5 inhibitors for 4 or 5 years by his primary pulmonologist, and then his shortness of breath was not improving, so he was finally sent to us for further evaluation and management. The patient gives us history of pulmonary embolism 4 years ago, one episode, and he also had DVT at the same time. And he says since then his breathing has never returned back to baseline. He always felt dyspnea on exertion. He was started on anticoagulation after that first incident, but unfortunately had a hemorrhagic stroke. So could not finish the full 3 to 6 months recommendations of anticoagulation. And then he's progressively got worse. He also had a prior history of leg hemangioma for between the age of 8 to 22, and he had multiple surgeries for that. There was also a history of abdominal AVM, and as I said earlier, that prior to coming to us, he was started on PD-5 inhibitor for his pulmonary hypertension. On presentation, he was function class 2, and his CTD evaluation was negative. And when I say CTD, I'm primarily looking for antiphospholipid antibody or lupus anticoagulants. Past medical history, he had CKD, hypertensive. He had one episode of amaurosis fugax, which we don't know exactly why it happened, and just one episode, and family history significant for hypertension and coronary artery disease, no smoking history. And on examination, his resting arterial sats were 89% on room air, but no overt signs of right-sided failure, no JVD, no accentuated right-sided, loud P2 or any leg edema. So this was his pulmonary function testing result. He walked up 320 meters with profound desaturation, obviously given oxygen, and this was his initial echo, which showed a PA pressure of 35 to 40 with cardiac index of 1.4. RV showed mild to moderately reduced systolic function and moderately enlarged RV. This was his VQ scan. And Dr. Gopalan, you want to comment on?
We only have the Q scan, and what it shows is multiple segmental perfusion defects. Now, I would always say make sure that you compare it with ventilation, or at least know if the chest X-ray shows that there is no underlying parenchymal lung disease.
So
we have the ventilation scan at the bottom, and it's normal ventilation. So this would be a mismatch perfusion defect.
And CT images, his lung parenchyma was essentially normal. There was mosaic attenuation. This was his cath hemodynamics. This was his initial catheterization. So roughly PVR of close to 5, as we discussed earlier, and at that time IVC filter was also placed. And now I have some of the images for pulmonary arterial angiogram. So I would request Dr. Gopalan to.
I just had a question for Dr. Gopalan. Yeah. So after the echo and the VQ scan, if the CT has not yet been done, is there any specific thing that we should, often the practice is to just get a non-contrast CT or a high-resolution CT. Is there, would a CT with contrast or with any specific?
I think if the patient didn't have renal impairment, I know you said your patient has got
Yeah.
CKD, but if the patient did not have CKD, and if there is no history of contrast allergy, you might as well just go for a CT pulmonary angiography rather than an HRCT, because at some point you're going to need a CTPA. So don't do two CTs, one unenhanced and one enhanced. Just go for one CT, because if you do a CTPA, you can extract the parenchymal information from that as well as the pulmonary information. So just go for one. Now, in this particular patient, if you did have renal impairment, is there any point in doing a CT? I would say yes, at least an unenhanced CT, because you can look at the parenchyma, and it's important to look for mosaic attenuation. So I would say it's better to do an unenhanced CT than no CT at all. So this pulmonary angiogram is real-life pulmonary angiogram. So it's, if you go to the next one, I think you've got another one which is slightly better. So this is on the right side. This is an AP view. What you do see is the catheter tip is in the right lower pulmonary artery. Now, we're going to be looking for the 5 signs that we already look for. So the first thing is there any occlusion? So if you think about the radiology talk that you had yesterday, he told you an important thing, which is the pulmonary arterial anatomy follows the bronchial anatomy. So you've got 10 segments on the right side and 8 segments on the left side. Now, again, going back to yesterday's first talk where he talked about A1, A2, A3, even if you don't know what is A1 and A2, at least if you can say this is the right upper lobe pulmonary artery. So in this, there are, okay, so if you just follow, so that's the right upper lobe pulmonary artery, and you've got the apical branch, yeah, the posterior branch, and then the next one, the next big segment down below.
Oh,
yeah, so anterior branch. So there are the 3 segments of the right upper lobe. Then you come to the one below. So at the lobar level, the middle lobe artery, you've got the medial and the lateral branches. Now you can see even the size of the vessel, compare it to the right upper lobe artery, is very, very small. Normally the transition is, it's big at the proximal, and then you go through a smooth transition to the periphery. Now this is much more irregular vessel even from the very proximal end. Yeah, thanks. And
Maybe
then
on this.
Thank you very much. And then you have the right lower lobe here. Now you see that there is a bump here. It should be smooth like this. So what it means is there's possibly some intimal irregularity at this point. Then as you come down, the vessel has to be transitioning smoothly, and what you have is abrupt truncation of the vessel. Now the problem is, these are features of CTEPH, but they are very distal, because if you listen to the surgical talk, 2 talks before, he said proximal, according to the UCSD classification, is if you've got it in the main, lobar, or segmental. If you've got the disease mainly segmental to subsegmental, it's group 3 disease. So at this point where what you have is, there are some features of thromboembolic disease, but it's predominantly type 3 and beyond on the right side. And then on the left. Yeah, and then there's one more, I think. Yeah, so this is on the left side. I think there's one more better one of the left. Yeah, this is a better one of the left side. And what you do see is, like for example, that is like a pouch defect. So abrupt truncation. All you have is the vessels are very small and attenuated. You don't have all of the proximal vessels. If you just go one before, if I just count the number of the vessels, there are possibly 8 segments here. So the number is okay, but it's just that from the mid-segmental level, you've got very attenuated vessels. If you go to slice number 2 of your angiogram, okay, the one before on the right side, yeah, one before that as well. Now, this shows you a very important feature, which is normally when you do an angiogram, you need to have vessels going all the way up to the lung periphery. In this, the last 2 centimeters are devoid of vessels, and that is a very important feature to show that there is distal attenuation of the vessel's architecture. So you have to see it going all the way up there. If it doesn't go all the way out there, there is a good chance that you're dealing with distal thromboembolic disease. Now, there is an important differential, which is this distal CTEPH or is this idiopathic pulmonary arterial hypertension where you have peripheral pruning? The one after this, the next one. Now, with idiopathic pulmonary arterial hypertension, you don't get these abrupt truncation. What you will see is the vessel kind of tapers as you go down. You don't get, if you go to the next one, on the left side, you don't get these defects like this. And there definitely should be vessels which are like this, but going very, very small out to the periphery. So you don't get, the pouch defect is the most sensitive out of all the 5 abnormalities that I told you about. So I would be happy to call this thromboembolic disease, but predominantly segmental to subsegmental type 3 disease.
And it looks like a lot of people are very interested in Dr. Gopalan's interpretation of this. So during the hands-on session, we're actually going to go through these films bit by bit, both looking at cross-sectional imaging as well as DSA pulmonary angiography. So if you're interested in that, please come upstairs.
Can I just ask a question? Before the arteriography, I was impressed, and maybe I missed something, at the disparity between the assessment of the right ventricular pressure on echo compared to what we saw at the right heart cath. And that, I mean, oftentimes, at least in my experience, the echo can overestimate the RV pressure. But I mean, how do you rectify these two, the differences? And maybe I missed it, but how about
No, you're right. I also noticed this difference in his first echo when he presented, and these were his cath numbers.
Usually, I'm sorry, what was the echo?
40.
Sorry.
Yeah, so usually it is common for it to underestimate. The echo doesn't underestimate because when you're looking at the TR jet and drawn envelopes, sometimes if you do not have a good TR jet, then it's often underestimated. But what we are seeing now actually with very sensitive echo is that if the echo tech doesn't draw a good envelope where if you even catch those few RBCs, some of the echoes are actually overestimating the pressures, and that happens when you use a very, very sensitive probe and you catch every RBC that you're seeing. We are seeing that too, but I think the false positive and false negative rates with echo are, probably close to about 20% on both sides.
So, I mean, the trap to avoid is getting this echo and thinking that the rest of your diagnostic algorithm is done.
Yes.
We even recommend that the number is really secondary, tertiary, way in the bottom of the list, to just look at the RV and the description and look at how that compares with the LV, because I think that is really what we need to focus on, because this happens so commonly. And again, this is another area where the diagnosis also gets delayed too.
And I think if you're highly suspicious of pulmonary hypertension, I think it would be a really good idea to make sure the echo lab does at least saline contrast to get a better TR jet, so that it does definitely increase the chance of knowing the right PA pressure.
So I think after our multidisciplinary discussion, this gentleman was deemed inoperable disease. We started him on medical management, started him on riociguat. He's tolerating it well, titrated to max possible dose of 2.53 times daily, and doing well. Now the question for him was if he should be considered for BPA, or will he be a suitable candidate for that. And I'm sure next talk is by Dr. Lin, and we will have more insight about what and when and what should be the patient selection for BPA, and if that will improve his quality of life or his hemodynamics.